Good afternoon. My name is Dr. Clement Muka. Today I'll be talking about an area right deep in the cerebrum, and the upper portion of the brainstem. This area consists of nuclei, and these nuclei, they are known as the basal ganglia. Its primary focus is to monitor the motor functions of the body. That's all it does. And these nuclei, they are organized in a particular fashion. You've got the putamen, which is one of the nuclei. When combined with globus pallidus, it forms what is known as the lentiform nucleus. So we've got this group that is putamen with globus pallidus, giving you the lentiform nucleus. You've got the putamen in combination with caudate nucleus, and that will form the striatum. Now, the striatum and the lentiform nucleus, they give you what is known as corpus striatum. Corpus striatum plus corpora claustrum. These are the nuclei. When you are combining them, they give you the basal ganglia. So these are all the basal ganglia. And specifically today, we're going to talk about one of these basal ganglia. The reason we're looking at this one basal ganglia is because of the patient who has just walked into my consulting room. And this patient presents with tremor at rest. This patient presents with bradykinesia, very slow in motion, very slow, very markedly slow. Postural instability. The patient there's postural instability and can hardly stand in a particular fashion. There's rigidity. So I was forced to say, let me send this patient away to the x-rays people, the radiology department, the people who can do the tests, brain CT scan test, people who can do MRIs and all that. The results came back very fast, and I was told that no, the patient has this one nucleus out of these many nuclei, this group of nuclei known as basal ganglia. There's this one nucleus known as substantia nigra. Substantia nigra has got two portions. It has got the portion that goes to, they call it pars compacta. And there's this part, and this part goes to the pars recticulata. And then the results say, the pars compacta, which has got dopaminergic neurons, those neurons are gone. It has lost those neurons. And you must remember the pars compactum and the pars reticulator, they must be in unison with one another. They must always be equal to one another. No one out of these two should overpower the other. Otherwise, there's going to be instability here. There are going to be problems. There are going to be problems. Now, it is clear, they say, there's a neuronal loss in the pars compactum of the substantia nigra. This causes then an imbalance between the pars compactum, compactor and the pars reticulator. This pars reticulator overpowers the pars compactum and of the same nucleus, that is substantia nigra. And this then causes depletion of dopamine, because the dopaminergic neurons have all been lost. They've been lost. They are lost for whatever reason. For whatever reason, I don't know what could be responsible for this. But they are lost. So there's no dopamine coming out of those. And because there's no dopamine coming out of those, there's now an imbalance. And you must remember what normally happens here. There's a connection between the dopaminergic fibers and the fibers of globus pallidus. And these neurons, they are connected to the thalamic fibers, and these thalamic fibers are connected to the brain cortex. To the brain cortex. And the cortex, that's the area that controls, motor function. So now, there's a disparity between these two systems. You've got a substantia nigra that's actually differentiated into pars compactum and pars reticulator. But the pars reticulator is overpowering the pars compactor because the neurons here, which are dopaminergic, are lost. And because they are lost, so now there's no way, there's an inhibition. There's an inhibition of a part that is not supposed to be inhibited. That is the thalamus. The thalamic connection, that is the one that goes straight to the brain cortex. And the brain cortex, that's the area of the brain that controls motor functioning. So now, this has been disrupted. There's no way that there can be motivation or activation of the brain because the thalamus has been cut off. The pars compactum side has given rise to hyperactivity, and the pars reticular side has given rise to hyperactivity. This imbalance cannot be afforded because this imbalance inhibits the thalamic connection between, the thalamic connection between the thalamus and the brain cortex. The cerebral cortex, actually. The cerebral cortex. And cerebral cortex, as we know, is the area that controls controls motor functioning. So that is why, the dopamine depletion, the problem of dopamine depletion has caused this problem. That is why the patient presents with a tremor. A tremor. This is a tremor. The patient is not supposed. And this is tremor at rest. The patient presents as what? Postural instability. The patient can't stand properly. The patient can't. There's a difficult gait. Has got a difficult gait. The patient suffers from what is known as ataxia. The patient can't stand properly. The patient is rigid. This is a condition known as Parkinson's disease. And my patient is over 65 years of age. So this is the problem that we have now. And then we ask ourselves, what is it that we need to do? We know the problem. The problem is dopamine depletion. There's no dopamine because the pars compacta, this of substantia nigra, the dopaminergic neurons have been depleted. They're all lost for whatever reason. Whether we don't know the damage. Maybe because there's a drug that's often used known as racapine. Racapine is known as a dopamine depleter. I don't know if it's because of that. Calcium channel blockers like diltiazem, for instance, they are known to cause this problem, Parkinson's disease. Anything that interferes with dopamine. And that is why we need to give dopamine in order to help this patient. But there's a problem with dopamine. If you give dopamine in the blood, once it gets into the bloodstream, it can't cross the blood-brain barrier. It can't cross. So that is why you need to use levodopa. Levodopa. Well, we have an enzyme known as depocarboxylase. Depocarboxylase is an enzyme that will transform levodopa. Preferring levodopa because it can cross the blood-brain barrier. And then it gets into the brain. It will be able to help now because the dopa decarboxylase, that is this enzyme. This enzyme is going to transform levodopa into dopamine and carbidopa. We need dopamine. That's what we need. We need dopamine. Carbidopa, it's fine. It's just a supplementary material that's formed because of the breaking of levodopa. So you get this dopamine in the bloodstream, and you get the dopamine now in the brain, right in the brain, and it helps the situation. The patient becomes better. You see the patient being able to move now faster. Patient being able to, because there's dopamine. Dopamine depletion is responsible for the sluggishness, the problem. Sometimes they say there's a spontaneous activation of inferior olivary nucleus, which is in the brainstem, and which normally is connected to the cerebellum, and it would cause the tremor. It could cause the tremor. It's normally found in essential tremor. But then this should not be confused with what is happening here. Yeah, there's a problem of bradykinesia. Bradykinesia is slow movement because of the deficiency of dopamine. Dopamine is not there because the dopaminergic neurons have been depleted by whatever. Injury, I don't know. Could be calcium channel blocker, I don't know. It could be, if it's a calcium channel blocker, maybe you can use verapamil instead of diltiazem. Diltiazem is your cardizem. So that's that one tends to be to cause this. I don't know. It's associated with Parkinson's disease. So one has to be careful. It is used intravenously in when you treat these patients. We don't have a tablet like an oral dose. We just use, but then still you must watch out for Parkinson's disease, because it tends, even when you're using Resipin, you need to be worried that, hey man, I mustn't introduce a problem that was not there, that of Parkinson's disease. These patients are amazingly treated very, very well if the diagnosis is made early and one knows. If a patient comes here and is moving slowly, and of course, in that 6th decade of life, 7th decade of life, it's important to understand that, you're not going to expect to get this at 20 years of age. You're going to get it in the 60th, birthday, after the 60th birthday, going to the 70th. All those people there, if they present with rigidity is a hallmark of Parkinson's disease. Rigidity is a hallmark of Parkinson's disease. The neurochemical pathologic hallmark is that one of neuronal loss. Neuronal loss in the substantia nigra. Substantia nigra, and we know which side of the substantia nigra we're talking about, the pars compacta, as opposed to pars reticulata. Pars reticulata is actually associated with the globus pallidus. And, if you have activity of that side, then you're worried that the thalamus is going to be inhibited somehow. And you don't want the thalamus to be inhibited, because the thalamus is your only connection to the brain, to the cerebral cortex. And cerebral cortex, that's where the activation for motor functioning takes place. That's where the whole control is. So you want that connection. So this inhibition, because of dopamine depletion, this inhibition of the thalamic connection, the thalamic fiber, that is, thalamic fiber that goes straight to the brain, to cerebral cortex in particular. When you say brain, cerebral cortex goes to cerebral cortex. You don't want that. You don't want, because problems, you won't be able to help this. Sometimes, we normally talk of as this be motor functioning and overemphasize that. Sometimes 50% of the patients, they present with pain. This is not what you expect. You have pain, you'd associate it with sensory nervous system, but they present with pain. Please take that into account. All you have in mind is that the substantia nigra is instrumental in everything. Having its pars compacta, having its pars reticulata. The domination of pars reticulata over the pars compacta is the problem, because that is the problem that introduces hypoactivity of the side of pars compacta. That is the side. That is the problem that introduces, the dominance of the pars reticulata. This difference is the one that causes inhibition of the thalamic connection to the cerebral cortex. And the cerebral cortex, as we know, is the one that will cause, or will make sure that the motor functioning is proper. Motor functioning will be proper if this happens. And this is one of the This is one, if you understand that, you understand the group of nuclei that are involved, and you will know that these are the basal ganglia, and you know where they are. They are located in the brainstem, the upper portion of the brainstem, and deep in the cerebral cortex, in the cerebrum. Deep in the cerebrum. They're deep in the cerebrum. Right. Then you find them there. These have got one function: monitoring of motor function. You will not forget that. You will not forget that. That's what you know. And you know that you are dealing with a very organized system here of nuclei. They are organized. Putamen with globus pallidus to give you lenticular nucleus. Putamen with caudate nucleus will give you striatum. Striatum with lenticular, with a lentiform nucleus, will give you corpus striatum. Corpus striatum with claustrum will give you all the basal ganglia. You can't forget this. You can't forget this, because that's the organization, and that's what you're looking for. You want to. I will be able to control. If there's any problem, then I'll always check the laboratory and say, guys, please just check my basal ganglia. You see a patient who presents with rigidity. That's the hallmark of Parkinson's disease. You see a patient who presents with postural instability, difficult gait, a patient who presents with a tremor at rest, that patient, those are, those are the cardinal signs or symptoms of Parkinson's disease. Thank you very much, guys.